I believe, back there. He's our tech. I know everybody is in their offices or in their couches or wherever you're at in work. We want to make sure we give a good thank you to our team that INHS and EMS Live at Night, and Sean and his team for doing this. Thank you guys very much. I think that the opportunity to do this is huge. My name is Mike Helbock. If you don't know me, I'll give you a little more background. I spent my career in the fire service here in Seattle, King County, and have been privileged to be able to travel the world and offer lectures. And I want to thank every one of you. I hope I have most of where everybody is at, but we got connections from across the United States that wanted to come in here, from the East Coast, Midwest, West Coast, from the UK, Australia, New Zealand, Singapore, Taiwan. If you're there, I want to say thank you. My colleagues north in Canada, my colleagues south in Mexico, and certainly in North, Central, and Southern Americas. Thank you all for being a part of this. I do have a little disclosure to get started, and I'll sort of get into this. I need to let you know that I have a dog in the fight, if you will. Sick Not Sick is a program that I wrote. It's published, and every time I share in front of an audience, I'm obliged to say that I did that. So there we go, made the publishers happy, and I'll go from there. So as Sean, as you quickly introduced, again, I'm from the Seattle King County region. I spent my entire career in the Seattle King County area, and I'm very proud of the work that certainly we have done and my colleagues around. I spent most of it in the fire service as a paramedic. I then was promoted to a division chief of EMS training and the King County Medical One program, where I spent time with my current colleagues in UW Medicine, and it's been a great run. And so part of Sick Not Sick, when we get to this introduction, will come basically why I wrote it. And I want to get to something that's been very important to me early. And I want to share a slide of a gentleman that means a great deal to me. As a young paramedic or in the fire service, and I know that I'm speaking to an audience that completely gets this, and this is one of the reasons where I really wanted to do this. Learning classroom content is one thing. Trying to translate it to the field is completely different. And when I was young in the paramedic program or in the fire service, it was very frustrating to me that we were expecting the book to try to teach the performance in the field. So when I started to develop Sick Not Sick, it was clear to me, I think I was onto something. And I want to share this gentleman right here, Dr. Michael Kopis. At the time, was director of the paramedic program at Harborview and director of the ED and the originator of Airlift Northwest. And he was a huge influence in my life early. And when I wrote the program, before it went to publication, I went to Dr. Kopis and I asked him, I said, am I onto something? Does this make sense to you? And Dr. C was a man of, quite frankly, a few words, unless you were in trouble. And he made it very clear that I was onto something. So with his guidance and his sort of blessing, I pushed it forward. And with that, I think it would help me understand what a culture of excellence is, both in EMS and the fire service. And I would be remiss if I share this talk without thanking Dr. Kopis as well. And I've actually seen a few other people online. One of them is Dr. Carlbaum. If you're on, I know you're around there. Dr. Carlbaum has also been a big influence on helping me really amp up the idea of Sick Not Sick, which stay tuned because I may be coming up with a new edition. So that said, let's get into this thing. So give me your time, give me your space, kick back wherever you're at, loosen your belt, kick off your shoes, or again, wherever you're at. And let me sort of take you on this journey, because I believe that this idea of understanding critical state, sick, not critical, not whatever, is a huge part of what we do. So let's talk about what is it? What's it all about? Well, the reality is, if you're an educator and you're reading page 157 of virtually any textbook that's out there in emergency medicine patient assessment, you're seeing the words general assessment, general impression, initial assessment. And again, unless you can translate that to a practical or psychomotor performance, it just never made much sense to me. So what Sick Not Sick is, in my opinion, is just a practical, real-world approach to the initial assessment or the general impression. Your ability to walk into a scene, look at some key clinical data, and make a pretty good decision of where they're at clinically. It's not a diagnostic tool, although you will be able to decide what areas are of concern. But in my book, this is the idea of us, and there are many seasoned providers in this room, in our chat room right now. And I know you can walk into a room in less than 10 seconds, have an excellent idea of whether you need to act aggressively right now or take a break and start working them up. So when I first wrote it, it was for those that really needed that experience. So let's keep going. So sick, not sick, it comes into play regardless of what you're going on. In fact, every single call you'll go on that has a patient, I believe you'll incorporate sick, not sick. Whether it's a minor fender bender, everybody's out waving their finger, you're number one, or whether it's a major intrusion where the Ford wins and the Honda loses in trauma. Maybe it's a hand in a meat grinder. Maybe it's in a processing plant. Maybe it's at a decompensating 16-year-old asthmatic that's trying the best she can to take that last little bit of albuterol from that MDI, whether it's that or whether it's a 13 or 14-year-old kid that's fallen off of a balcony onto his forward chest and shoulders and face and has a LaFord fracture. It doesn't make any difference. Sick, not sick comes into play every single time you acquire a patient. So let me spend a few minutes on this. This is a really important slide. So if you can kind of get an idea, if you've never listened to me speak, I get pretty energized, but I'm going to hold here for just a second because I want to spend some time on this. In my opinion, there's really only two categories of if you will, of physiological state of the patient. They're either critical and need action now, or they're not. And that's the term sick, not sick, where it came from. So as you start to decide, and I'll show how I've built this program and hope that you can either validate or maybe hearing this for the first time, process the information to land on this decision. But here's where I want to share for a minute. Now, if I was in front of you right now, I would be able to sort of use my hands and my wand to kind of show you, but on screen, I'll show it to you this way. With only two options, sick should be on your left, not sick should be on your right. That's easy in the early time of being a provider, if they're easy, if the data's easy. But here's where I think some of you have either landed before in your career or maybe landing there still today. And that is right here, what I call the I don't know zone. And the reason it's important to understand sick or not sick is because whatever treatment you decide is driven by the decision, sick or not sick. So if you land in the middle, I'm not quite sure, I don't know, I'm open, whatever, I'm hoping someone else shows up to make the decision zone, you have not made a decision of critical state, and therefore you cannot develop a treatment plan. I want that to just sink in for a second. And again, I'm sure there are many of you out there going, Mike, this makes perfect sense. I get it. Let's go to the next slide. But let me just sort of let this sit in there, because every one of us, including myself, physicians on board at some point in their career as well, have got into a middle of a sticky case and they're going, I'm not quite sure. There's enough information to get me excited, but not enough to get me over the board. So when you're in the I'm not sure zone, one, you haven't made a decision. Two, you have no treatment plan. So what I'm saying is this: if you ever find yourself there, get out of there. Move to one side or the other. Do it based on data. Don't just flip a coin, but you've got to get out of the I don't know zone. So with that, let's go on. Now I can say EMS providers, but if I've got hospital folks here and ED, and if you're fire and anyone else, the bottom line is initial providers, people that render care early in the case. They have to do two things really, really well. I think they need to be able to make decisions better than anybody on the planet. To me, these are generals. These are people that can make decisions in sometimes the worst scenarios. And I'm speaking of you. Your ability to make decisions is what puts you in front of the patient's care. Number two, you've got to be able to treat based on the decision. Now, this is important because I've seen this before where early in when we were starting to share this, I would see some providers with little experience call everybody sick. Everybody is sick. And they would do that because they knew that that would call for the entire cavalry would show up. Everybody would be there. The reality is not everybody is sick. And in fact, you probably already know that. Almost 80% of every call that's called in 911 are not sick. It's a small subset that actually become critically ill. Our job is to figure out who those patients are through clinical data, and we will do that in this session today. So make decisions, treat patients. One of my favorite all-time slides. This is a paramedic in Seattle, this young lady. And I love her, first of all, because she rolls her shirt sleeves up. That's just so cool. And not only that, she's an amazingly talented paramedic and a firefighter. But I want you to look at something different. This young lady has been going on 20, 22 runs, 23 runs a day for 10 years. She's a busy, busy paramedic. And yet, on the next call, she can still look at her face. She can still furrow her brows and she can curl her nose and go, dang, I don't know what it smells like, looks like, what I'm about to touch, but I can still be that way. We are human. And in the process of whatever bothering her, she still needs to make a decision. Look at the data, flesh through it, and make a decision. So let's talk about that. As an educator, if I was sharing this in front of you right now, I'd be walking to the left side of the room and engaging you on the left, and walking to the right, engaging you on the right. And I'd say, let's come up with this plan. What is the decision? Well, let's talk about it. So first, let's give a definition. In my opinion, sick is any patient that you believe is physiologically unstable based on indicators. There's no flip of the coin here. These are based on indicators, and I'll show you what those are in just a moment. But if you believe these people are physiologically unstable and they may change to the worst, they put them in the sick category. So let's just look at who these people are. Some of the bullet points. Go with me on this. People in respiratory compromise. I've learned many years ago that people that are short of breath will get worse before they get better. And as a result, I am very interested in this problem. So people in respiratory compromise, I put in the sick category until proven otherwise, because I'm convinced they'll get worse before they get better. If they get better on your watch, so be it. But at least I was in a plan A, B, and C. So that's the first one. Hemodynamic compromise, really quick, just a relationship of blood pressure to pulse. I'll give an example. So a 68 male, maybe some discomfort, chest discomfort, and the chief complaint's not factored in yet, just the hemodynamic compromise. The heart rate is 182 beats per minute with a pressure of 48. So without knowing exactly what's wrong with him, and certainly most of you can have an idea that what could be some culprits here, the bottom line is he's sick. He's got a hemodynamic imbalance between a rapid tachyarrhythmia and a hypotensive state. Sick till proven otherwise, act on it. Remember, decide and treat. Decide and treat. Let's keep going. Who else is in the sick category? Neurologic impairment. Dr. Kopis is the one that really drilled this home with me, and that's why I speak of him so highly when I do this session. Dr. Kopis was a neurologist by design, by the way. And he's the one that would share with me that this head that sits on all of our shoulders, this 5 to 6 pound melon, constantly wants to seek gravity. It wants to just fall off your shoulders and seek gravity. The only reason it's not is because it's oxygenated and perfused. So your ability to snap left and snap right is an indication of perfusion and oxygenation, at least from the start. So people that are neurologically impaired, there's something that we care about a lot, and that is their ability to maintain a patent airway and minute ventilation or volume, their ability to breathe. So neurologic impairment, regardless of cause, trauma, metabolic, vascular, it doesn't make any difference. Neurologic impairment, till proven otherwise, in my book, will be sick till proven otherwise, based on their inability to maintain a patent airway and offer good minute ventilation. Okay, let's keep going. So I don't know if anyone out there uses a term that I've got in parentheses here, but skin signs or color. I actually sometimes will call it vitals, skin vitals. And here's why. Because you can't fake pale and sweaty. And if I was in front of you, I'd say, go ahead and try that. In fact, if you're on the couch with your jammies on, go ahead and try that. You cannot fake pale and sweaty. So when I come into a room and I see somebody with their skin has lost that underlying ruddy tone, and there's a bead of sweat from diaphoresis from their non-exercise sweat, that bothers me. It's a hemodynamic problem till proven otherwise, and I make it into the ding ding sick category. Let's keep going. Body position. And you are the best at this, by the way, everybody. I've seen you work. I've watched you work for literally decades. You can walk into a room and you can appreciate in a medicine patient, people that aren't really ill or sick will find positions of comfort. They're completely relaxed on the Barca lounger, feet are up, legs are crossed, and they've got a latte in their hand. But when people become distressed respiratorily, metabolically, hemodynamically, when they become distressed, they seek positions of distress. The most common we know is, I wish I was in front of you right now, I could hear you. You're probably saying tripod. That's a good one. Slumping, falling over, laid down on the ground, supine. So body position, especially in medicine, is a big deal. Look at it when you walk through the door. In trauma, what I care about is what's still attached to your body and how bad does it look. So in other words, obvious trauma and mechanism. So they don't tend to seek positions of comfort when you're traumatized. You tend to sort of hang on for life. So I'm looking, for example, bilateral femurs, open forearm, and a gaping head injury. So to me, I'm impressed by the mechanism that would have caused that. I'm impressed by your injuries, sick till proven otherwise. Here's the last one for everybody in the room. Normally I would ask to put your hands up, but if there's anyone in the room that's been like less than a year out there on the field, this one's hard for you. Your index of suspicion, that bucket is fairly empty if you've only been around a year. But all you need to do is look left or right to those colleagues that have been doing this for 10, 15, 20 years. Their index of suspicion bucket is full to the top. So when a senior player, and I'm not saying paramedic, I'm saying a senior provider looks at me and says, Mike, I don't like this call. I've seen a few of them. I think we should get the gurney. You know what you think? You know what I'm going to do? I'm going to go get a gurney. And we'll talk about that beyond. So index of suspicion is huge, especially if it's based on clinical data. Well, I hope that sounded that okay. I think sick patients could die en route to a hospital. That's exactly what I think. As a result, I'm going to develop a plan A, B, and I'll definitely have a plan C. And I'll say this now and I'll repeat it. Because high level, high performing EMS in-hospital medical providers, they are proactive on the treatment of patients, not reactive. If you're only reacting to change, you're behind. A high-level functioning EMS provider is a proactive opponent. You've already figured this out. You've got plan A, B, and C. If they shift, you've already engaged plan B. And I'm proud of every one of you. I've seen you do it. And I think this is one of the reasons why you do well. You don't just act on how they're doing. You are ahead of this. This is a 16-year-old kid working with his dad on a log chipper, and a huge branch came back and impaled the guy. This kid is definitely sick by mechanism and obvious injury until proven otherwise. I pause for just a moment. Your black screen is by design. It's okay. Here's where I say again, I wish I was with you guys so bad. Oh man, I've missed you so much. All right, let's keep going. So we've spent some time on sick, okay? This is the part of the talk normally I would say, if there's only two categories, and I just spent 15, 16 minutes talking about one, the sick category. My question to this audience then who's not sick? And the reality is everybody else, right? It's everybody else. Remember, the I don't know zone doesn't count. Those, if you go there, and I know you have because I've been there with you, that is not a decision. You can't stay there. There are no patients that get to stay in the I don't know zone. You've got to go one way or the other. So let's go the other. So who's not sick? Well, Sean and Mark, honestly, at EMS Live, I could say everybody else and the talk would be over, but I think you'd probably be a little bothered by me. So I better fill in the blanks here. So who's not sick? Let's do it together. Who's not sick? I believe these patients are physiologically stable based on clinical data. And we're going to get to those very soon. They're stable right now. And I quite frankly, I think that doesn't mean, by the way, not sick does not mean not hurt, not ill, don't treat. It doesn't mean that at all. It just means their clinical status seems like it's holding at this time. And I'm happy with that. Let's go on. So who's not sick? Respiratorily, they seem fine. As you know, people that are not ill respiratorily, and I've got the lung guy on, so I know he's probably all smiles on this one. They breathe comfortably, sit comfortably, mouth closed through their nose. When I see people with their mouth closed comfortably breathing through their nose, I don't think respiratory till proven otherwise. That's not the case. So if they're respiratorily stable, I'm comforted by that. That's a good one for me. Hemodynamically stable. Now, if you'll notice, sick not sick does not use blood pressure early to make a decision of critical state. You don't need it. You folks are so good at understanding this. All you need to do is, maybe in this case, get a distal pulse. If they've got a strong radial, skin signs are warm, dry, and pink, you can already process that hemodynamically they're looking fine. You're going to validate that with a blood pressure, but you don't need to pull a blood pressure cuff out to appreciate hemodynamic stability early in the call. Again, you'll use it, but not within the first 5-10 seconds. Again, neurologically stable. They can snap left, snap right. They can answer. They're articulate. They can make articulate sounds with their tongue. They can answer my questions. I like this so far. Skin signs appropriate. And when I say that, that's people both of color and not of color. And the more experience you have, you can tell that there's still, you can still see that ruddy undertone of oxygenation and perfusion, of red blood cells with oxygenation. They offer this underlying ruddy tone. And if you can see that and then touch and it's warm and dry, just know that you should be comforted by that up front. People that are sick do not find positions of comfort. As most of you, I'm sure, at your homes and wherever you're at right now, they don't find positions of comfort. They find positions of distress if they're sick. So if they're not sick, these are the folks that could be reclined on the Barca lounger, sitting on the chair, sitting on the couch, not having a problem. Mechanism of injury. You could be injured, but if the mechanism is minor or low, I'm not too worried by that because I don't think that mechanism probably could have killed them. Just make sure we're only talking about the mechanism here and not a comorbid issue like maybe they had an acute coronary syndrome or a diabetic problem or stroke. I'm talking about just the mechanism here. Okay. And lastly, if your index of suspicion is low and your index of suspicion bucket is full because you've got experience, you need to listen to that. You couple that with all the rest of these clinical data, and you can make an excellent decision, at least right now, how the patient is. Remember, everybody, this is one other thing I'm going to share. Sick, not sick, when you make that decision, is simply a point in time. That's just right now. Can things change? And I'm sure you're all nodding your head. Absolutely, they can. But this is just a point in time right now. Be prepared for change. I don't think sick, not sick people are going to die en route to a hospital. They could if they change, but most of them are not going to do that. They're going to stay there. We'll talk about this as we get a little further. So this was a young gal, 14, 15-year-old gal, got stung on the back of the hand by a bee. She didn't have allergies to it, but it swelled up pretty big. She had a pretty good little edema on the back of her hand. Mom got a little excited, didn't like that at all, call 911, EMS shows up. They find her scared, but not short of breath right up front. She was warm, she was dry, she didn't have progressive hives around her. She wasn't short of breath. The nasal cannula, I'm not sure that wasn't prophylaxis or whether that was a little bit of a placebo. I'm not sure exactly what that was for, but the bottom line is the clinical signs and symptoms of this patient with a localized swelling from a bee sting put her in the non-sick category. Now we're going to keep an eye on her, make sure it doesn't change, but there's no history or index that makes me think otherwise. Okay. All right. Pause for a second. Just make sure everybody's doing all right. I'm going to stop for just, if you can hear me in there, Sean, I'm not going to pause long, but is there anything popping up that we need to address from my wonderful colleagues across the globe?
There's nothing in the chat box, but if anybody wants to unmute their mic and has a pressing question, feel free to do so.
Yeah, I'll wait for just a minute or two. I really like to engage people. So if there's something that just pops up and needs my attention, we can do that. I'll wait for another minute or so.
Just give her mic. It sounds great.
Oh, my Canadian buddy, you're just too kind up there. Is this making sense to you, my friend?
Oh, absolutely. It just takes me back to the day one and Doesn't matter how many times we hear it, it just reinforces the fact that it works and it's easy and it's growth. It's just part of the laws of what we do.
Thank you, Big John. If anybody know my friend from Canada up there, is an extremely talented EMS provider up in the Canadian province up there. Thank you for that. All right,
You're
well,
far too good.
let's keep putting forward then. If you do have something, let me know. I just want to let you know that we need to treat based on our decision. You're going to see a little bit more about this. This is a complete degloving of this woman who got ran over by a car. Degloved her from her groin to her foot. And I just want to make sure that you know that we incorporate mechanism, obvious injuries, things like that. And let's be honest, I'm leaving the slide up for a little bit of impact right now for the rest of y'all. So the bottom line is treat based on your decision. I first wrote this many years ago, and I contemplated whether I should put a time factor on it. I didn't know if that would be a good idea, but let me explain. Many of you in this chat room right now can do this way faster than 60 seconds, and I understand that. But where I was trying to share is that when providers walk into a room based on experience, some of you don't have 20, 30 years of experience. Maybe you're only in for a year or two. What I'm suggesting is a reasonable period of time needs to be within a minute. You should be able to make a decision of critical state within that period of time. Some of you do it faster. I know that. But just know that if at some point, if at a minute or so, you can't decide, you're in the I don't know zone, and you're going to go ding, ding, ding. Oh, Mike was talking about this. I can't stay here. Because when you're in that zone, there's no treatment plan. So you should be able to make it in a short period of time and get off from there. There's only two types of patients that we see. We categorize them as sick or not sick, but we know by the chief complaint, it's either medicine or trauma. Let me start with the first one. Let's start with medicine. So let me explain this. So when I developed the program, this is the part that I spent really a lot of time with. I spent a lot of time at Harborview. It's a level 1 burn trauma center in Seattle. And I spoke to a lot of people, a heck of a lot smarter than I. And I'm asking them about, what is it you're looking at? When you walk into a room of a trauma patient or this, that, what are you looking for? And these are the pieces that I put together as a medicine patient. So certainly chief complaint, NOI, straightforward. But the 5 key clinical indicators that you're looking for: respirations, pulse, mental status, skin signs, body position. That's it. At the end of that box, there is enough data in front of you to make a solid clinical decision of the patient's metabolic or hemodynamic state. That's what you need to know. I'll build it all upon that moving forward, but here we go. Medicine, chief complaint, NOI. I'm looking for respirations, pulse, mental status, skin signs, and body position. And in fact, before I click the slide, here's a quick test. And by the way, you're not graded on it, but here's a quick test. Of the 5 clinical indicators, starting with R, end with B, respirations, pulse, mental status, skin signs, and body position, how many of those 5 can you really fully appreciate without ever touching the patient? In my opinion, it's 4. Now, you can appreciate if they have a pulse, if they're conscious, but you don't know how well they're doing with a distal perfusion. You kind of need to validate that one. But from the door, I can tell respirations. We talked about that. I can look at their mental status, skin signs. I can appreciate body position. So 4 of the 5 indicators that could put these people in a box 6 feet under can be appreciated from across the room. And that's what a lot of you senior providers do every day. You walk in, you take a quick look left and right, you appreciate key clinical data, and you've already processed your decision. Let's see how this comes into play. Once you get the data points, you make a decision of sick or not sick. Here's a question of the audience. How many of these data points need to be in the sick category before you make a decision of sick? How many do they need to have? In my opinion, the answer is 1. That's my opinion. Could they have 2? Oh, absolutely. In fact, you've seen them with 3, maybe even 4. That's another book I'll write called Sick, Sick, and Sicker. But all you need is 1 to put them in a sick category, because all it takes is 1 of those to put these people in a bad spot. So if they are profoundly tachypnic with poor tidal and terrible minute volume ventilation, they're sick. If they're unconscious, unresponsive when you walk through the door, they're sick. If you walk through the door and they're pale and sweaty and they have no color to the skin, they're sick. Now you start adding 2 or 3 together. You not only have a plan of action in the category of sick, but now you can start your treatment plan. And here's how we do that. Everybody, please look at this quickly. This is not specific care. It's just priority care. Let me explain. If they're in the sick category, everything about that is quick. Update ALS if there need be, life-threatening emergencies, treat them, O's if need be, get a history, a good set of baseline vitals, put them in an appropriate position, i.e. if they're sitting up, they're hypotensive, we may need to sit them down, depending on their clinical status, get a repeat set, do a reassess and go from there. Look in your upper left, I believe it's on your screen. Always, always include what is the chief complaint, what is the nature of illness, and what is my index of suspicion on those clinical data. That is going to put you in a rock solid spot to make a decision. If they're not sick, and I'll spend a time on this one and then watch where this goes, everybody. If they're not sick, in other words, those key clinical data early, respirations, pulse, mental status, skin signs, body position, none of them were suspect. I wasn't worried about any of them. Okay. Remember, not sick doesn't mean not hurt, not ill, don't treat. Doesn't mean that. Just means right now they look stable. Put them in the non-sick side and start working them up. Blow some O's if you need to. Care for any obvious injuries if need be. Get a sample or OPQRS, whatever you do. Get a good set of vital signs. Do a full exam if need be. Offer any appropriate treatment and go from there. If they stay down that line without a change, they're going to end up in the non-sick decision, whether they transport or not. That's up to you. I'll let you decide that. But look what happens halfway down the non-sick side. And these lines were put sort of at key places in there. If you suddenly find the history changes or the vitals change, or now my blood pressure is not supportive of a non-sick stable, at any point, please look, those are dotted lines moving to the left side, and they go through to the sick category. So dotted lines moving to the sick side. Notice, everybody, there are no lines, no arrows coming from the sick to the non-sick, and I'll spend just a second explaining why. Just know, in my opinion, 100% of all non-sick patients could move to the sick category if they change. Most won't, but they could. But interestingly, if you put them in a sick category, which, by the way, they earned, remember, by clinical data, very, very few will ever come back to the non-sick side. If you don't mind, let me just share maybe a couple. How about you go on a call for a 32 male, history of diabetes. You get there at the, you get there and you find him unconscious. Someone said that he had a seizure. He's got snoring respirations. By clinical data, he is sick till proven otherwise. Body position, ventilation, neural status. Okay. Perfect. You've made a decision, your treatment. We want to give them an open airway, patent airway. Someone grab a BP, give me a glucose. We're going to work the patient up. Get a glucose of 20. Okay. You decide to offer some level of glucose enrichment, however you do that. And within 5 minutes, you repeat. His sugar is at 122 milligrams per deciliter. He is neurologically intact. He's dry. He's warm. He's embarrassed. And his friend that called, he's happy he's back. I'm going to see if Sean, if someone will answer this. What would you do to that patient if he completely came back after a bolus of sugar, however you choose to give him, and now he looks completely well? What would most of you do for this patient now? I'll pause for just 5 or 10 seconds. If there was someone there to watch over and take a look and make sure he was at least cared for. Anybody popping in on that, Sean?
No one's jumping in the chat box quite yet.
Well, I'll tell you what we would do.
I see a medical direction, someone said.
Of course, right. You're going to follow whatever the course is. Our course would be, I would leave him there. If he came back from this episode, and it doesn't mean he may not get ill again, but if he came back from this episode with a glucose greater than 60 after his glucose repeat, and he's neurologically intact and pink, warm, and dry, and he can eat, so we already tested his swallow reflex, and someone there to watch him, we leave him. Here's my point. That's a patient that went from sick up front to a non-sick left at home. That's my example. I mean, up front,
chimed in with make peanut butter and jelly.
Oh yeah, thank you for that. Peanut butter and jelly and don't give them a Diet Coke. I actually watched someone do that once. He said, I think I've got this. He gave the guy a Diet Coke. I said, you're right. That 1 calorie, I think, will bring it back home. But I made my point, everybody. The other one, by the way, I'm going to share with you is a postictal patient. He had a tonic seizure, had his history of it. He was initially, he was postictal when you arrived, which is unconscious, snoring respirations, urinated on his pants, all the normal stuff. You have to call sick till proven otherwise, because you don't know anything about this patient. Within 5 minutes, his brain resets, comes back up. You follow up, maybe you get a glucose because you're not sure, and everything now looks good with him. If there's someone to keep an eye on him, I'd leave him home too. Follow up with your medical provider, take a look at stuff, but I'd leave him. I made my point. There's very few sick patients that'll ever migrate back to not sick, but 100% of the non-sickers, if they get worse, can migrate over. All right, I've made my point on that one. I'll move on. Trauma patients, look at this. The beauty of this is that it's almost the same. Chief complaint, except for now it's mechanism instead of nature. Respirations, pulse, mental status, skin signs, and obvious trauma replaced body position. Because again, I don't care what position they're in. I care what's still attached and what's it look like. So let's see how this comes into play. I'm looking at a 16-year-old child struck by a Suburban at 37 miles an hour in your town, USA. Kid was thrown 32 feet before he struck the tarmac. Prior to arrival, I'm already thinking sick till proven otherwise by pure mechanism. But you get there and you find him with an open femur, an open forearm. He is unconscious with snoring respirations. So I've got mechanism, sick, respiration, sick, mental status, sick, obvious trauma, sick. We know that. But immediately in the sick category, without a doubt, your treatment plan is now crystal clear. This is why sick, not sick comes into play. And I appreciate my colleague up in Canada saying this. You can walk in, and once you make the decision and you're comforted by that, your treatment plan is where your medical direction offers to you, and away we go. Remember, the treatment here is just priority care. If they're sick, move into the sick category, offer all the things that make them sick, and treatment. Remember chief complaint, mechanism, and index. If they're not sick, and you've all seen plenty of not sick, traumatized patients in your career, that's fine. And if they continue on without changing, they'll stay in the non-sick side. But if anywhere during this process from north to south on your sick, not sick plan, on the non-sick side, if they change and get worse, move them to the sick category, reevaluate, and go from there. Okay, I hope everybody's doing okay. I'm just watching the clock here. We're about 38 minutes in. The reason is I've got something at the very end I'm hoping we have time to do, and I believe we will. I've worked very hard to try to get this timing down to engage you with a couple of, I'll just say, very interesting cases. I'm hoping I can get that to you. Anyway, let's do this. Other factors affecting sick, not sick. We just talked about them. Nature of illness, mechanism, and index of suspicion. The reason I post these here is because if the clinical data is not clear, in other words, the respirations, pulse, mental status, the data is not clear, then use one of these to help shift you one way or another. You go on a 62-year-old male, it came in as chest discomfort. You get there and the guy looks pretty good. He's sitting there comfortable, pink, warm, and dry. His hand is no longer on his chest. It was there for about 7 or 8 minutes. And he has got a good distal pulses. He's not short of breath. And you're thinking right up front, he looks clinically stable. Put him in the non-sick category, start working him up. You do so. You get a glucose maybe on him, you get an OSAT on him, you get a full set of vitals, and everything's still looking good. He tells you then what bothered him is that his brother, his twin brother, has got a 4-way bypass going on right now at a local hospital, and his dad died at 50 of an acute coronary syndrome. So this guy has a history suggesting an opportunity. I'm just saying use those to help guide you where this might go. Always include them in your plan. So one of the things that we generated when we built the program, listen carefully to this, and I'm wondering if any of you do this. When we developed the program and I put it into play in the Seattle-King County region, one of the things I asked all training officers to ask the crews to do is this. Once you get the tone out, for example, 32 female, left lower abdominal pain, near syncopal episode. One more time. 32 female, left lower abdominal pain, near syncopal episode. The minute you get the tone out, you move off the end of the ramp on the tarmac and decide which way to turn, start processing. What are the top 3 probable scenarios that would cause a 32 female to have left lower abdominal pain and be near syncope? So generate the probable scenarios that'll cause it and then develop a treatment plan to care for that. For example, if it comes in as a trauma call with entrapment, what do I need to do? Well, I need a truck company. I need more people. I may need more manpower. We need to know where we're going to take the patient. If it's a head injury, I want to make sure that I offer proper ventilation if I need to at all. I want to make sure that I'm protecting the airway, cleaning the vomit. If it's airway considerations, do I need to clear the airway first? Do I need to suction the airway? So you're going through and you're already developing a plan of action before you ever arrive at location. I'm willing to bet a lot of you do this, especially those that have been doing this for a while. Okay, so here's a good call. 68 male, comes in as chest discomfort. Okay, en route, I'm thinking acute coronary syndrome, maybe musculoskeletal, maybe just some, it could be a pulmonary insult, could be all kinds of things. And I'm developing a treatment plan for each one of these. I come to the door, fire department, walk through the door, that's what you see. You're on the call with me. He's a 68 male, hand clutched to his chest. Levine would be proud right now at that position. He's got his other hand on his thigh. He's leaning forward, trying to breathe. He's got no color to his skin with a bead of sweat down his brow. From the doorway, everybody, what is he? Not what's his complaint, what is he? Exactly. He's sick from the doorway. I think I have an idea that something's going on in his chest, but I don't know if that's a pulmonary vascular disruption or whether that's a straight acute coronary syndrome. I don't know that yet. And interestingly, the gal in the background, she's trying to pronounce diaprididamenol to the dispatcher because that's his medication. If that's the case and he's in the sick category, they need immediate BLS and ALS care and transport to whatever medical facility you guys decide. Sick patients need your care. Sick patients need your transport. Sick patients need you. And that's why the EMS system was developed. Okay? Whether it's ground, you make this choice. This is not for me to decide in some room across on the West Coast over here. Whether you decide ground and diesel or you like aero rotor, that's your choice. You make those decisions. So let's do this again. Let's come up with another call. Ready? 68 male, chest discomfort. All right, I'm back in the rig. I'm heading your way. I'm thinking the same thing. Acute coronary syndrome, maybe a pulmonary disruption, maybe just musculoskeletal. You walk through the door, and this is what you see, a cruise at your arrival already. Not same patient, but if you will, go with me on this picture. He is comfortable, leaned against the back. He's comfortable. His mouth is closed. EMT says, sir, we're just going to have a little nasal cannula. He actually was on a nasal cannula. They're taking it off of him right now. Evidently, this guy's got a history of some COPD, and he has no respiratory complaint. Vitals are fine. Skin signs warm and dry. What he says is his wife, they recently got the oxygen. His wife saw him doing a little huff and puff. All he was doing is coming downstairs. She got excited and called 911. Based on this, clinically, the patient, you agree? He looks stable, right? I agree. It doesn't mean we're not going to care for him. We need to still work him up. And if he stays not sick or stable through the call, then we'll come up with a plan. But if anywhere during that process he changes, I'll change with him. That's the process. So not sick patients, they need your care. You might decide to transport or not, that's your choice. But if they change anywhere in the middle of that call, you change with them. So if the status changes, vitals change, cardiac symptoms reappear, they get more short of breath, seizures, neurologic status changes, what do? Move in the sick category. My question to this audience, and if I was in front of you, I'd ask this right now. If now he's in the sick category, did you make a mistake a few minutes ago when you put him in the non-sick category? What do you think? Did you make a mistake? See, I don't think so. I don't think you did. I think you acted on clinical data. Remember, not sick is not a bad plan. It just means that right now, this guy looks pretty good. Let's work him up. And then halfway through, if something changes, you change with him. So no, I don't think you made a mistake. And in fact, you know very well, you've been on plenty of those calls. The only time you make a mistake is when you don't make a decision. If you can't decide sick or not sick, you have no treatment plan. Okay. So if that's the case, get everybody back in, get them in the back of a rig, make your decision for ground or air rotor transport, and away you go. I put this one down here for a couple reasons, because I believe there are some mistakes that I've seen, not often from the senior folks, because they've already made the mistake and they don't often do it much anymore, but sometimes it's us newer guys when we were first starting off, pardon me, delaying the initial decision for maybe my colleague who's got more experience. He'll be right behind me. I'll let him make the decision. No. That's you. Do that. Failing to respond to new information. If they start to get worse, you need to come up with a plan B. You need to act on that, right? You need to be proactive, not reactive. And the last one is tunnel vision. And I know everyone's got their own definition of this, but I've seen some pretty egregious tunnel vision. And in fact, I've been there myself. I could tell you a long story if I was with you, but I'm afraid it would eat into the time. So just know I've been caught with serious tunnel vision before, and I know that I can't do that. All right, this has nothing to do with this call, nothing to do with this talk. Sometimes it's a good idea just to back up, put a good old latex glove on your nose and head, and blow it up with your nose. Yeah, that's it. That's all I have. That's all I had on that. Just trying to bust it up a little bit. I got a friend out east that knows exactly who this is. Let him know I got him on camera here. All right, let's keep going. Spoiler alert. I want to let you know this. When all else fails out there, when all else fails and you can't figure it out or you've got too much going on, just know this. Treat what you know you have for sure. Treat what you know you have for sure. If you do better than anyone else, treat airway, ventilation, and distal circulation, you will always be in front of the patient. Just treat what you know you have for sure. And don't let those three little letters go without your care. Patency of the airway, excellent minute ventilation. Do something about it if they're not doing it, and see if they have distal circulation, and do something about it if they don't, and you'll always be fine. Okay, well, let's give you, these are just text case studies, Chalk Talk. Let's give you some of these. Normally, again, Sean, as we get going through there, there'll be a discussion about whether they think they're sick or not sick. So let's encourage them to type if they want. I'm just interested to see what they think. But case number one, here we go. 32 female, complain of abdominal pain near syncope. I heard that one before. En route, you and your partner discussed this. I'm thinking ectopic till proven otherwise. I have a funny feeling, so are you. Why? Because she's the proper age. It's a she, certainly, and there's abdominal pain with a near faint. That could be an ectopic till proven otherwise. It's a big deal, and if we don't treat it, we could lose this patient. So let's put that at the top of our list. So sick with a treatment plan. Where am I going to go? How fast am I going to act? Which hospital am I going to go to? Take care of it. Let's do another one. En route. How about the flu? I mean, she could have the flu. Generally, that's not sick. I mean, it's not crazy, unless she's completely volume depleted, but let's just look at this. Flu till proven otherwise, not sick. Treatment plan. I'm going to get a history. I'm going to maybe do an orthostatic change, see if there's any changes there. Let's get a glucose on her, make sure all the right things. And if she stays stable, then we'll go from there. Last one's appendicitis, a little vague. Let's make it even more. Let's make it even more. I'm not sure where that came from. I got a little thing on my screen here. Appendicitis. How about a burst appendix with peritonitis? So massive pain. She's febrile. She's almost pre, if not fully septic now. Well, that's sick till proven otherwise. So I got Sean, can you see my screen?
Yeah, I can still see your screen. I just see the red mark.
I have no idea what that is.
I
don't know what that is. Someone drew on my screen.
That was nice of them.
Yeah. I've never had that happen before.
I will see if I can get rid of it, but
Okay.
If not, it's not terribly distracting.
Well, it is to the presenter who put together the program.
Yeah.
All right. Nonetheless, everybody sit back. I'll read it to you. Yeah, I don't know where that came from. Let's see, I don't know if I can get rid of it either. Oh, no, I don't want to do that. So I'll read this case. You knock on the door, apartment door, no one answers. You do it again. Female voice says, I'm in the back bedroom, come on in. Fine. You approach the patient, lying on the supine in the bed. You observe no breathing difficulty, respiration 16, not labored. She has a strong radial pulse of 90. She appears conscious, yet she's alert. She's concerned. Her skin is flushed, warm and dry. She says a couple days of abdominal pain with intermittent vomiting and a decent fluid intake. So that's the case. Let's just see what happens. So using this, chief complaint is abdominal pain, vomiting, fluid intake. Let's look at the clinical data. Respirations are no difficulty at 16. Pulse is strong radially, distally at 90. Mental status, conscious and alert. Skin signs, warm and dry. Body position, supine. Couple that clinical data with your key indicators of chief complaint, nature of illness, index of suspicion, and what category would you put her in? I agree. She's in the non-sick category. Remember, not sick doesn't mean not ill, don't treat. She's clinically stable right now. Let's treat her. And if anything changes halfway down when I do orthostatics or anything, and I find out if she's bleeding or anything like that, we can change. But if she stays down that list at the end of my exam, she's a stable patient with abdominal pain. And we'll seek whatever medicate or whatever care needs to be done. Pretty straightforward. I'll give you another one. Case number 2, 28 female. It comes in the dispatch, apparent overdose with vomiting. By the way, the red line's gone, Sean, so you are like my hero right now.
I can't take full credit. Someone bailed me out in the messenger. So
okay, all right, good. Thank you, everybody. All right, so 28 female. Ding, ding, ding. You're on a call, everybody. Apparent overdose, vomiting. En route, I'm thinking changing the level of consciousness, and with that changes the respiratory drive. That is sick till proven otherwise in my book. I'm thinking vomiting, airway concern, so vomit is concerned. So I'm thinking suctioning. With that, it could offer more airway problems. To me, sick till proven otherwise. The last one, poisoning. Maybe it's just an oral ingestion, accidental, intentional, I don't know. But in my book, where I come from, all overdoses eventually cause you to die till proven otherwise. So I don't like these cases. So I tend to be very aggressive early and decide if I need to peel back. Everybody, here's the real case. Patient's lying on the couch, boyfriend's house. Multicolored vomit all over her and all over the floor. Scene secured by law enforcement on your arrival. You find a lethargic female, pale skin, cool and dry, breathing 20-24 times per minute, but no abnormal airway sounds nor any signs of respiratory distress. As you quickly move down to get a distal pulse, you do in fact find an extremely weak yet rapid rate of 150 beats per minute. Let's look and see how the data plays out. The chief complaint is overdose, multicolored vomit, respirations 20-24, a little fast, but nothing that she's not sounding bad, but it's just fast. Pulse is weak, radially 150, mental status lethargic, poorly responsive. She's pale, cool, and dry, body position supine on the couch. It should be clear as a bell to everybody on this chat room right now that we have a sick patient, period. This patient's sick. Now, is this an intentional overdose? Is it an overdose? I'm not really sure what it is yet, but I do know that hemodynamically, neurologically, somewhat respiratorily, and with the nature of illness and index of suspicion, we have a sick patient who'll proven otherwise. And we go from there. This actually has nothing to do with the talk either. It's just a way cool picture of my hunting dog. So everybody say hi to Bear, and away we go. So mechanism of injury, I'm shifting now to trauma. So I'm going to pause for about 2 minutes and just ask Sean if there's anything that I need to know about, if there's anything popping up. I'm watching the timing carefully, and I think we're going to be fine.
yeah, nothing. Everyone there, all the chat boxes just interacting with your sick and not sick diagnosis on patients. So there's a heck of a lot of interaction on that end.
Good.
But yeah, nothing question wise.
Okay, that's fine. That's fine, everybody. And continue to engage the best you can if there's something you want to ask. And remember, when I do discuss this, I'm sharing it with the idea that you need to process this case the way you do it yourself. Work it the way you do. This is simply how I process this, and you can agree or disagree. Mechanism of injury to me is very clear, yet the vectors and the types of injuries are very different. height and size of vehicles, damage sustained, directional forces. And I'm not going to get into what I call the kinematics of trauma, if you will, but I will say this. It's important to understand the mechanics of trauma and the injury that can happen from both low, moderate, and high level of directional force, okay? There is no doubt, everyone sees this picture, that that is a major mechanism, and everybody in that car should be considered sick till proven otherwise. That is a major, and kudos to my colleagues at Seattle. They are just simply some of the best I've seen at, well, they like to take tops off cars, are good at it. But I'm just making a point. And here's what Dr. C taught me many, many years ago. Here's what saves lives in trauma. And sadly, your name is not attached to it individually, but you have a huge role in it. In other words, EMTs don't save lives, paramedics don't save lives. We save lives through our action. So we're a very collegial group here. Here we go. What saves lives in trauma, in my opinion, is rapid assessment, rapid treatment, and rapid transport. And that is everybody that's out there in this chat room. You have the ability to affect that. Every one of you, you bring value to this particular call. These are all real calls given to me by my colleague, Dr. C, many years ago, and I continue to use them today with pride. This patient was thrown out of the car, had a terrible neck injury, but I start with rapid assessment of a patient in a trauma accident, rapid treatment of a patient en route. This one made it into the talk because they made a choice to intubate him in the back of a moving rig. And I know that's a whole different conversation today, but to paralyze and intubate somebody in the back of a moving rig when this young paramedic did this was pretty impressive and completely effective, and it changed the outcome very positive. But that's another whole talk about doing stuff in a moving rig. And the last one is when you're on a call and this is a traumatized, heavily traumatized patient, make the decision to get them somehow as fast as you can to a high-level trauma center, because your actions will speak volumes once you get them to a high-level trauma center. Together, you can save lives. Subliminal slide, just letting you know there's only two opportunities, sick or not sick. The I don't know zone doesn't exist. You're dispatched to a home of a man said to have fallen from a roof. So en route, I'm thinking, well, this is not good. I mean, first of all, 1 story, 2 story, I don't know. Let's just call it 1 story. For sure, head injury, C-spine, that's what I'm thinking. Impaled objects, maybe the guy impaled himself on a fence or a tree branch. Multiple fractures, orthopedic injuries, whether it's arms and legs, whatever. My partner said, how about this one, Mike? He fell off the roof because of an acute coronary syndrome, or he fell off the roof because he's a diabetic, or he had a stroke. Well, that opens Pandora's box. The bottom line is every time you come up with a plan, come up with a treatment option, and be aware, here's what the scene really is all about. 47 male, back patio, tended by his wife. In fact, he's sitting, she's got him propped up. It looks like he wants to fall out, but she's got him propped up. Immediately, somebody takes C-spine, because we agree now is about a 15-foot fall from a 1-story roof. Just make sure it's in line. He's in respiratory distress, rate of about 30. He's conscious, but he's tired. He's pale, small lac on his head. And interestingly, he's got his hands clutched to his left anterior chest, and there's blood between each finger web space of his left hand. So something's going on underneath the anterior portion of his chest. Pulse is fast and weak, complains of shortness of breath, confirms 15-foot fall. Here's the data, 15-foot fall to a patio. We look up and we can see there's a gutter line where he hit the gutter, and there's a little bit of his shirt hanging from the gutter, the edge of the gutter. Respirations are rapid at 30, pulse is weak, mental status conscious, and he's tired though. He's pale, and his obvious trauma is head lac and some anterior thing to his chest. Always include chief complaint, in this case, mechanism of injury, and index of suspicion. This patient, without a doubt, is absolutely right. You have a sick trauma patient. And we'll talk about a very similar call when we run the last few live case studies here at EMS Live. Did that for you, Sean. I'm having fun with this. I don't know about you guys, but I'm having fun with this. This is actually really good. All right. Hey, you know, I say this all the time. They don't die because you can't diagnose the condition in the first minute or two at the scene. They don't die from that. They die when you don't provide what they're needed, which are the ABCs. The more it gets confusing, the more you got to pull back and treat what you know for sure. Sick or not sick is the case. Sick or not sick is the talk. Now what we need to do is let it be your turn. So I'm going to hit each one of these. I'll give you as much information as I can. They're simply still picks. Just know that. They're still picks. I'll let you decide. You can do it through your own chat room between all of you, but I'll simply give you the answer after about 10, 15 seconds. Okay. Call comes in as a one car into a pole, one person dead behind the wheel, 4 people still in the vehicle. Based on mechanism alone, they are. I'm going to give you that one. That's a pretty easy one right up front. No problem. Let's do another one. Call comes in as an 8-year-old female. She comes in, she's had a fever with a single episode of vomiting. Mother called 911 for care. You come into the room, mother is very concerned, nice home, everything looks good. You find this young girl in bed. She is mildly febrile, about 100.7. She says she's thrown up. She doesn't feel very well. She is not short of breath. She is, her skin signs are fine. She has distal pulses, and neurologically, she's intact 100%. So based on these clinical signs right now, remember, sick not sick doesn't determine differential diagnosis, just determines clinical state. What is she? I think not sick and work her up. I think that's where we need to be. We need more of a workup. I want to get a glucose on her. I want to get more vital signs, get a temp on her. I want to do some more work. But right now, she seems at least clinically stable. This call comes in as a seizure. You walk in, someone said that he was seizing, full body seizure. When he was done, they rolled him over on his side. All you know is this: he is unconscious with snoring respirations. From the doorway, what is he? Yeah, you're right. We know that by neurologic status and ventilatory status. Those two things in combo. Now, mind you, this may be one of those cases that if it's truly postictal and he works out of this and he comes out fine and his glucose is okay, I don't know what's wrong with him yet. I might put him back into the non-sick category and let him be watched. Maybe, we'll see, but not right yet. This little boy, this is a really cool case, interesting case, not cool, sorry. This little boy was coming down the stairwell. Please note the difference between his foot and the bottom is only like 6 inches, but his foot caught a little bolt on the end of that ladder. And as he stepped off, his leg spun. So he has a distal spiral fracture of his leg and he hit the ground below. Palms are down, so he caught himself. When you arrive, he is screaming in pain wants his mother. He is pink, warm, and dry, screaming in pain, knows exactly what's going on, does not want to talk to you, not short of breath, but clearly has a distal fracture of his lower leg. I'm interested to know what you think. Mechanism was only a 6-inch fall to the ground. He was neurologically stable, respirations, pulse, everything's fine, except a pretty ugly fracture. I put him in the non-sick category. I don't think that's going to kill him and route to a hospital. I'll treat him, we'll take care of him, but I don't think that's going to kill him and route. That's my idea. Here's another one. This was a 10-year-old boy that was sitting on a set of bleachers that watching like a football game or something. He fell off the back of the bleacher and struck his head on the asphalt below. When you arrive, you see his mother sitting over the top of him. That's who she is right now. All you see, he appears to be unconscious with blood coming from the back of his head with a 10-foot fall down to a concrete or asphalt below. Based on this, he is. Yeah, there's no doubt. Everyone, I know what you're thinking. Sick till proven otherwise. Don't miss the whole call. The minute you categorize them, now you got to come up with a treatment plan. What are we going to do? How are we going to treat a 10-year-old with a potential TBI, open head injury, unconscious? Maybe it needs to be having ventilatory support. Maybe we need to control things, and let's just go from there. Okay. I've got 2 more of these left, and then I'm going to have enough time to do this, I think. You are second in on a motorcycle accident for a man that hit a pole motorcycle. That's all you know. When you walk in, you notice this crew is already moving him toward your rig. It's like they waited for you to show up. You ever seen that before? They waited for you to show up. When you get there, here's what you see. There is this, this was a stop sign that, please appreciate the irony in this whole case. He was impaled on a stop sign, and they cut the end of it off with a homatro tool, which is a hydraulic tool. He is like a 28-year-old male, penetrating injury to the upper right, upper left quadrant. He is still conscious and a lot of pain. Hemodynamically, he's got distal pulses. He's still pink, but he has this rod stuck up through his gut and into his chest. Based on mechanism, what do you think? Yeah, me too. This guy's sick. Here's the last one of these. Let's do this one together. The call comes in when you're at your firehouse, whether you're in the EMS squad, or if you're your EMS squad or your firehouse or wherever it is you work. It's about 1:30 in the morning and you're in bed sleeping. And what you hear is this pounding at the front door of your squad. Someone gets up to answer the door. It's about a 45, 48-year-old male. He says, my stepdaughter is in the car. She's a diabetic and I need your help. I just picked her up from a party with some friends and I need your help. You run out, you open the car door, and that, everybody, is what you see. She is barely conscious. She has no color. She's breathing about 6 times per minute. So neurologically obtunded, lethargic, obtunded, ventilatory. She's only got 6. She has no color of skin. Till proven otherwise, she is what? Absolutely. So we get her out of the car. This dad is convinced that all she needs is her insulin. So he hands you a vial that he pulled out of the refrigerator before he went and picked up his daughter and says, my daughter needs this vial of insulin. She's a diabetic. Please help her. Now, if you're a seasoned medic, you're already going, I don't think so. But if you're easily intimidated by the public, you may be a little put off by that. The bottom line is, ABCs first. Let's get her out. It's not a trauma call, just so you know. So this doesn't require a trauma call, but she deserves a full workup. So we're going to get her out. We're going to give her a patent airway. We're going to test her minute volume. If we need to ventilate for her, maybe interpose, let's do that. Let's get distal pulses. If she has poor distal pulse, let's at least elevate her feet. Or if you're an IV person, get something started. I want a glucose as soon as I can. And I'm going to run a trauma exam on her. I'm going to make sure I see from head to toe. Sure enough, when I go through my exam, she's got these little teeny pinpoint pupils. And dad sees you pull something out of your kit. And whether you spray it up her nose or whether you intramuscularly give it to her, or whether you give it IV, within about 2 or 3 or 4 minutes, she wakes up. Dad thinks you're a hero. Dad thinks you gave her what? He thinks you gave her insulin. And in reality, what you gave her was Narcan. This little girl stole her grandmother's pain cocktail for stage 4 respiratory cancer. And she was taking shots of synthetic opioid pain cocktail. It's an opioid overdose. And again, it's the idea, don't be intimidated by what you think it is. Look at the clinical data first and go from there. All right, Sean, I'm looking at the clock. Correct me if I'm wrong, but we have 20 minutes. Is that right?
Yeah, you do.
Good. I'm going to pause for just a second because I think we have enough time to do what I'm about ready to do. I'm looking forward to this. Is there anything we need to address, Sean? Any questions that are popping up, or anybody saying, Mike, turn it off, this hasn't been very fun, anything like that?
No, nothing like that. Just leave yourself about a minute window to go over your post test. And for those that didn't print it off, I gotta when he's all done, let me show you how you're going to get your certificate. But I want you to keep going, Mike. Go for it.
Okay. So everybody, let me take you on a journey. Let me take you on some live cases. We filmed these when I was back the division chief of EMS training back at Seattle King County, and I'm hoping these are engaging for you. Here's what I want you to do. Since I can't see you and can't be with you, I want you to work through these. If you're with a team doing this, work with them as a team. If you're by yourself, think of yourself with a team. But this is going to be a live case, and I'm going to challenge you on a couple of things, and we'll learn something at the same time. So the first call comes in and Mark, make sure that the audio is good on this too. But the first call comes in as an adult male entrapment at a local muffler shop. That's what the call comes in. As you pull up, here's what you see.
Fire 1 from 881. We're going to need an agent company and medic unit. How you doing, sir? We're going to take care of you. We're going to take care of you. Okay, let's get some oxygen on him. And let's make sure this car's not going anywhere. You want to take a look at that real quick? And we'll start working on it. Yeah, I'm going to get some oxygen going. We're going to take good care of him, ma'am, okay? We'll take care of him for you. Good, excellent. Let's go ahead.
So the scenario was this: he was actually those hydraulics were not underneath the car. He was on it was just a jack stand type thing that fell and pinned his chest to the ground. So the front part of his chest and part of his head was pinned. So the complaint is 55 male, shortness of breath, trapped under vehicle. Initially, the clinical data, respirations were rapid, pulse was sustained tachycardia greater than 100. He is conscious still. In other words, he knows you're there, but he's not communicating. He's cool and pale, and he has obvious chest trauma and some head trauma. So based on these data, what do you think? Sick or not sick? There's no doubt we got a sick patient here. There's no doubt. And I asked the question why. I'd like you to answer it yourself. There's enough clinical data here to make that go. The mechanism is one. A car fell on this guy's chest. That's one. But he's got a rapid respiratory rate. He's got almost a sustained tachycardia pulse-wise. It's present, but it's fast. He's conscious. That's good. I like that. But his skin signs are poor and his obvious trauma. So this guy's got enough indicators to call him sick. That's fair enough. So with that, let's go to the next one.
Okay, let's get that oxygen on him. We're going to do a quick blood pat down.
Andy, I got a little bit of fluid coming out of the ear here. So
Okay, great. Okay, he's not bleeding anyplace else. Let's get a stethoscope. We need to get moving with him, so I'm going to take a listen to lung sounds. We'll get him on a backboard and we'll get him out of here, okay? Once you get that oxygen on, if you could get a backboard for us, that'd be great. This oxygen's going to help you, sir. Pupils good. Okay. Yeah, let's get the backboard going so we can get him packaged.
Energy at the scene right now.
slow down your breathing for me, okay?
Engine 81 from 881. We're going to need to set up an LZ.
He just called for an LZ, suggesting they're asking for a helicopter. A little bit more data, not much though. Respirations confirmed again 28 plus. Heart rate still about the same. They did a GCS on him, Glasgow Coma Scale, and they got a 12. He's got a verbal motor deficiency there. Still cool and pale, still same chest injury. But I think you heard this EMT saying we need to move. So their plan is that sitting at the scene is not going to save this guy's life. Remember, it's the package deal. It's the rapid assessment. It's the rapid transport. It's the rapid packaging to a high-level trauma center that saves people in time like this. So let's see how it progresses. What I did was the whole call is run, and I'm just cutting it in pieces for you. Let's do another one. What would you like to do now? I'm assuming some of you may want to get him out of there. Whether you use a backboard or however you choose to do that, we need to get him going somehow. He's going to need a full exam. We need to get lung sounds. We need to get SATs on him. There's lots to do. So just appreciate this. But my question is, do you have any, and you can write this in your concerns, is there anything that's really delving you right now that you want to get done right now? And I'll wait only a few more seconds so I can make sure I get through this. And if that's okay, again, you can chat amongst your friends. Let's finish this one up. This call change.
Okay, you got the head. You can just tire out of the way.
As they expose his chest, they see
Okay, everybody.
this marked color change from his neck to his nipple line. Again, these are only 3 EMTs on this call. They've only been at the call
Let's get him
for
back
about
on the board.
3 or 4
Call it.
minutes.
He's foaming. Okay, let's get him moving in the back of the rig. Once we get him back there, we're gonna suction him. Okay.
The suction unit.
Just gotta do.
Okay, so if you look at the data, not a whole lot's changed other than they got a glucose on them. I'm happy that the crew was able to spark that really quick and get a glucose. That makes me happy. Just know that I want to make sure that's not the reason for his altered LOC. He does have an altered Glasgow, but it's glucose seems fine at 148. What do you want to do right now? And if you're saying suctioning, yeah, we need to think about that. What went from a non-rebreather because he was still ventilating, which is the difference between using positive pressure and a non-rebreather, the fact that he can still ventilate on his own. Now we have an airway and a patency issue. That trumps everything. So everything's going to have to change now. And we're going to have to be aggressive with suctioning his airway. If that's what you suggested, I agree with you. I'm going to share with you I don't normally do this, but one of the best secondary assessments I've ever seen by a team of EMTs that were en route to do a medic intercept to move to an LZ. That is the extension of this call. Please watch. You can make your own choice.
Okay, sir, I'm just checking to see if you have any other injuries here. Case feels stable. Eyes look good. That looks good. Looking in his ears, he's got blood from the ears. We already knew that. This looks. I'm not going to press on his chest too hard. I think it's
Watch. It's
unstable.
okay
as
if
it
you
is.
find something you
Listen
don't
to that
like.
sound, see if that's gotten any
Tell your
worse.
colleagues. Listen to him breathe.
Still pretty quiet. They might even be a little bit more quiet. Still getting some air.
I hear grunting.
Sounds a little bit junky. Okay, gonna press on your belly, sir. Just try to relax. Try to tell me if it hurts down there at all. Does your belly hurt? No?
We're about 3 minutes out from paramedic
Hips
intersection.
feel stable.
Want to finish the
Feels
exam.
good. Legs feel stable.
Respiratory 36.
Okay. That looks good. Push down my hands. Push down my hands, sir. Pull up. Okay, good, good, good. Okay, this arm. That looks good. Squeeze my finger. Great. Let go. Check this side. He's got this broken arm over here, so I'm not going to do anything more with that. We're just going to splint that to the board.
And they got the pulse ox right here.
Okay, yeah. What do we? Let's go ahead and clip onto the pulse ox. Got it. All right. Give it a second to get a good reading. Yeah, let's throw a bandage on that real quick. What's their pulse ox reading there?
I got 84.
84. Crap.
All right, so I'm not sure if you're watching all of this, but my question to you is going to be, what would you like to do now? Let's review the data. Respiration 28 plus now. Rate is still greater than 100. GCS is starting to fall, both eye, verbal, and motor response. Glucose stayed the same. Did you hear what I heard? I heard what sounded like grunting. I call it end expiratory grunting. It's all at the end of his expiratory cycle. Remember, everybody, expiration is a passive process. It shouldn't require energy. You require energy when you take a breath in. If you are requiring energy to breathe out, be very concerned with that. And end expiratory grunting in the face of a chest injury, to me, suggests that he's trying to do what's called PEEP, or positive end expiratory pressure. He's trying to self-PEEP himself. He's trying to keep his lower terminal air sacs inflated. So he's going, he's breathing this way. That absolutely scares me. Now, you know what I mean by scare. I'm not frightened, but it just, I'm impressed by his damage. Let me quickly share a quick call into Trauma Doc. And I know that I've got a colleague online right now that I used for a lot of this work. And I thank you for that, Doc. But I'm calling into Trauma Doc. Here's what you may have heard. Please listen in. So Medic 1 to Trauma Doc. Trauma Doc says, go ahead. Medic 1, Trauma Doc, I'm seeing a 55 male resulting from a traumatic asphyxia where he was pinned underneath a medium-sized car at his chest. Currently with a GCS of 8, vitals to include a BP of 72 palp, rate of 118, respirations greater than 30, and profound distress. We have him on a monitor with unifocal PVCs greater than 6 per minute to include a glucose of 148. Our plan is to treat the patient en route to a Harborview. We'd like a 20 cc kilogram bolus therapy of targeted fluid management. We have intubated the patient already, and we did have 23 at the lip confirmed with an 8.0. We had proper colorimetric change, but Doc, we're only getting 18 millimeters of mercury through waveform capnography. That is the call in. The rest of the call moves forward. Patient codes en route to Harborview. Bag valve mask gets progressively more difficult. If you're a part of this and you've been these calls, you know what's going on. He's developing this massive tension pneumothorax inside his chest. We offered bilateral needle thoracostomies. If that's your game, then you do midclavicular second intercostal, bilateral neothoracostomies. If you don't do those, maybe you'll do the new idea of midaxillary fourth intercostal and put a chest tube thoracostomy in. He had complete sub-Q air from his nipple lines all the way through his neck, just as we entered the ramp at Harborview. And folks, I'll tell you sadly, that as they opened the chest of this young man, within 40 minutes of the ED, they ceased efforts on him. He had massive pulmonary and vascular disruption of his chest. And this was a very, very sad call, but it didn't take away from the hard work from those EMTs, those paramedics that met them, the helicopter that sent them, and the level 1 trauma center that ultimately treated him. So I don't know if you felt the energy on that. I do have one more I want to share with you. I hope that I could share a little bit of learning in that. One of the key takeaways here is anytime you have chest trauma and you introduce positive pressure ventilation like we needed to, either with a BVM or endotracheal intubation or with a supraglottic airway, normally you breathe by negative pressure. The minute we introduce positive pressure to ventilate for someone with a chest injury, Pandora's box has been lifted open. You have to be aware that you could cause different levels of barotrauma, if you will, because you're entering positive pressure in an injured chest cavity. So please be aware of that. Talk to your partners, talk to the medics you work with, EMTs, talk to medics, medics talk to EMTs, and make sure this is a collegial team moving forward. Okay. Well, I've got 8 minutes. I cannot wait to share this one with you. You ready? We'll see. We'll end on this one. Let's see what happens. All right. Call comes in. Nope, that's not it. I just in case we couldn't do it. Call comes in as active labor. Woo, active labor. I'm en route. That's it. 36 female active labor. So that tells me I'm hoping full gestation, 40 weeks. That's what I'm hoping. Here is what you get.
31 and 47. This is an imminent birth, approximately 35-year-old female, white Suburban. The RP said you'd be on the road, flagging you in. 31.
Right there. All right.
Put on your OBGYN pediatrician delivery cap, everybody. Get ready. Listen very carefully to this. This is the husband.
It's not supposed to happen here.
I wish I was with you right now. If you're laughing as hard as I am, I never tire of looking at that. That's exactly what he said. This is not supposed to happen here. Quickly, full term, active labor. Respiration, no complaint, but fast. Pulse 98, no problems, bounding. GCS 15, she knows exactly what's going on. She's flushed, warm, and moist, semi-reclining in the vehicle. I call her not sick, but let's be honest, this is an imminent birth, I think. So it's not sick with an amped up idea. She's not clinically ill, but there's no doubt we have an emergent scenario. I want to move through this so we can get through in here. So I'm calling her not sick, but emergent. Okay. Not sick, but emergent.
What's your name, sir? Mike. Mike, okay, are you the husband?
Yes, I am.
All right, I'll tell you what, Pat, would you talk to him really quick?
Hey,
Ma'am, hi. Hi, my name's Mike from the fire department. What's your name? What's your name?
Lenora.
All right, Lenora, relax, relax. Lenora, are you full term right now?
I want
Is
you
this
to be
baby supposed to be
thinking, what would
delivered
you
right
be
now?
doing?
Okay, I want to take just a quick
You're on
peek,
the south.
and we'll see what's going on, okay?
I don't want this
Just a
baby
quick
in the
peek.
car.
Oh, you know what, Lenora? I think we're gonna have a baby here. Hey, Greg, we have crowning. This baby's happening right now.
You
Go
didn't
ahead and
hear,
look at that
she's
OB kit.
crowning. There's
Tell
perineal
medics
bulb.
47, we have a birth. We're gonna deliver this kid right here.
It's happening right now. So I want you to, what would you like to do now? I'm hoping you're saying I'd be getting out my OBGYN, I'd be getting my delivery kit, going through it, prepping the best I can, or would you want someone to just drive her to the hospital? I hope that's not your answer because this kid's going to deliver soon. So you need to prep for a field delivery. That's the bottom line. Okay. Let's see what happens with this young lady.
Hey, Lenora, can you tell me, did the bag of waters already break?
Yes.
It did. Did that? How long ago? Do you know?
An hour.
Okay. All right. That sounds good. That's good. Good. All right. Good. What's up? You having a contraction?
Yes.
All right. I'll tell you what, Lenora. What I don't want you to do, Lenora, don't push quite yet. Don't push. Breathe through
Don't
this.
you listen. Don't
Breathe
push
through
yet.
it. Breathe
Don't push
through
yet.
it. Breathe through it. Good. Breathe through, Lenora. Breathe through. Let me know as soon as it goes away. Okay. Let me know as soon as it goes away.
Okay, it's
All right.
going.
Okay. Good. Hey, big cleansing breath. In through your nose, out through your mouth. In through your nose, out through your mouth. Good. Hey, how many kids have you had in the past?
3.
All right. This is your 4th pregnancy too. Good.
I don't
Has your-
want it here.
Okay, I understand. You know what, Lenora? I think we're going to set up to have
We
this kid
planned
here.
it. I don't want.
It's going to happen right now. Your baby is already starting to come. Can we get Mike? Hey, Pat, can we get Mike in the back and maybe can you
Mike's
help
the
coach
dad,
your
by the way.
wife a little
I'd
bit?
want him
That
to
way
get
we
the
can
back
help
seat.
maybe get him around the other side or something. All right, good. Greg, let's go ahead and just do the cannula. I'm going to open the OB kit, get this ready. Okay, I've got my bulb syringe ready. Hey, Lenora, you really need to tell me when you have a contraction.
Okay,
All right,
okay.
there's no doubt that we're going to have this baby right here.
All
So when
right.
you have a contraction again, Lenora, look at me. When you have a contraction again, you're going to push. We want to have this baby. Go ahead, Greg. Go ahead.
I'm gonna bring some oxygen in here. I'm gonna go ahead and get it.
Okay, just relax. Good. Right there. Perfect. Okay. Mike, coach them as much as you can here. Here we go. Okay, here we go. Here we go. All right, here we go. Here we go. Okay, Lenore.
Okay, stop real quick, everybody. You heard the first one when she started the first contraction. We said, whoa, hang on, hang on. The reason we did that is because we weren't prepped and ready yet. What we try to do if we weren't really ready to do this, we ask her to try to breathe through a contraction. As many of you, I already know, you know this, but by her puffing, 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 she can't take that big breath in, which is the big squeeze. When the minute I watch a woman in labor do this, we know what's happening next. So try to avoid that unless you're ready. Now, as soon as you're ready, okay, when she's ready to push, have her push. If you look at those data, these points are fine. She's doing fine. So everybody, let's just go ahead and see what happens next.
There it is, the head. Excellent. The head is delivered. I got the head right now. I got the head, Lenora. I got the head. I got the head.
I'll talk about suctioning in just a moment when it's done.
Presentation on bulb syringing the mouth.
I'll talk about that at the very end.
Excellent, excellent. I don't see any meconium. It looks like clear fluid. I've got the mouth and the nose, Greg. Excellent. I've got the head delivered. Lenora, I've got the head out. This is
Watch this next move.
Look at me, Lenora.
Anterior shoulder comes down.
This is it. On the next push,
once this
we are having this baby. Are you ready?
Shoulder comes
are you ready? Here we go. Here we go. You tell me when it's contractions coming. Here we go. All right, I'm ready. I'm ready. Here we go. Push, 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 push.
Anterior shoulder, slight downward pressure. Once that's exposed, slight upward
pressure. I got it.
And that's it.
Here it is. I've got it, Lenora. Oh, you got your boy, my boy. There's your baby boy. Nice job, Lenora. I want to give him to the ENT really quick. I want him to dry him up real quick. We'll get your baby nice and dry. We'll do an APGAR. We'll get him right back to you.
Perfect. I'm going to finish this with an APGAR. As everybody remembers at 1 and 5. And if you remember what an APGAR stands for, it's appearance, pulse, grimace, activity, and respirations. Poor signs are 0. Great signs are 2. And you know that you can start off on a vaginal delivery like this. You could have a poor sign early, and then after a minute or 2, it could come up high. So just do it at 1 minute and 5 minutes. With that, everybody, I am coming to the very end. Okay. And I want to be able to say with 3 minutes left, we did it. We did it. Sean, I practiced this and practiced so I get right to the very end. So Sean, I'll tell you what, why don't you take over and guide us the rest of the way while I'm air hugging all of my colleagues all over the world here. I miss every one of you.
Yeah, absolutely. Why don't you, Mike, before you pass it back to me, why don't you go over your post test real quick if you got that in front of you, or I've got it in front of me. So either way.
I do not have it in front of me. Hang on a second.
I've got it pulled up. I can read it off if that's okay with you, sir.
Oh, actually, okay, go ahead, because I do. Oh, I do have it in front of me. I'm sorry for.
Perfect.
Hang on a second.
For those that regularly attend EMS Live at Night, they probably have already pre-printed it off. For the rest of you, I will talk about where you can find this and how you're going to submit to get credit for this lecture. But Mike, why don't you go ahead and go through your questions?
Yeah, I do have it here. Awesome. So Sick Not Sick program is question 1. It's designed as a practical field approach to the initial assessment or general impression. True or false? Absolutely true, right? That's what it's designed to be. So number 1 is true. Clinical indicators of a medical patient include all of the following except. The question number 2, they're all the following except a diastolic and systolic blood pressure. We don't need those 2 to make it a clinical decision. So number 2, you should have highlighted that one. They're all good except number 2. Okay. I see what you're doing there, Brody. You're drawing on my slide there. That's pretty cool. Differential diagnosis is required to determine sick, not sick. True or false? False. In fact, you don't need a differential to determine sick, not sick. That's number 3 is false. Number 4, determination of sick, not sick can be made in less than 60 seconds. True or false? Absolutely true. In fact, most of you do it faster. And the last one, can you make the decision of sick, not sick by mechanism alone? Yes or no? Or it is yes or no? The answer is yes, you can. John, with 1 minute left.
Man, you got this down to a perfect science. So, Mike, thank you very much for answering my email to do this. I greatly appreciate all the work you've put into this program, sir. I'm sure everyone will echo that. Real quick, those of you that are familiar with EMS Live at Night, you guys can say your thanks to Mike there in the chat box. Mike, you can obviously bring that up on your screen now, sir. But what I want to show is everyone else how you're going to get credit for this, just because if you're new to EMS Live at Night, you may not be familiar with that. So Mike, I'm going to steal your screen sharing here just real quick.
Yep. And while you're doing that, Sean, I want to make sure everybody knows, if you want to contact me, everybody, oh, sorry, it was gone already.
Oh,
If you want to contact me, I'll bring it back up at the end, either my email account, phone number, or my Facebook account. I want you to contact me if you need me. Anywhere in the country, anywhere in the world, if you need me to chat, I'd be happy to do so. Go ahead, Sean.
Perfect. Sorry about that, sir. All right. So those of you that are tuned in that are not familiar with EMS Live at Night, I'll go through this really quick. If you go back to the website that you actually found the link to participate tonight, if you found it through Mike's PR process, our website is healthtraining.inhs.org. You click on the EMS Live at Night and OTEP link up here. If you go over here to current EMS Live at Night courses, we need you to submit an attendance sheet for tonight. So if you click on this sheet, you can type in your name, your level of care, your email, your agency, whether you're paid and volunteer, and then you're just going to submit it to this email address that's listed right up here. Also, please make sure to print off one of these post tests, fill those out, email that as well, and then check back into this website tomorrow, and a course completion certificate will be uploaded with Mike's information, the topic, the length of time, and so on. And it will be a writable PDF that you will be able to type your name in, good for 1.5 hours of CE credits. Yeah, if you have any questions from me specifically, that same email, inhseducation@inhs.org, you can reach me at. I greatly appreciate you all tuning in. If you loved our program, come back February 9th. We're going to cover airway management. I will be presenting, as we don't have a guest lecturer, so I'll be taking care of that one. But Mike, if you want to, I'll stop sharing. You can put your stuff back up to end the night.
Yeah,
sir.
please.
The rest of you have a great night. Be safe, stay healthy, and we'll hopefully see you guys all soon.
Everybody, I'm going to put this back up on the screen so you can see this and make sure it's up there. I mean this, if you're out there, if you need me, if I can help you, my email address is there, my Facebook account, my phone number. Anywhere in the world, if you need me, I'd be happy to do so. And I just want to close, Sean, everybody, this guy is incredible. Sean has been just a real wonderful helper for this. And Mark, you're probably the unsung hero back there. If you're the IV tech guy, thank you for that. It's been an honor and a privilege. And if I said before, I mean it, that I really miss everybody. So hopefully I'll be able to see you again someday.